Very good morning to everyone. And at the outset, I'm thankful to the scientific committee, AIOS, and the local organizing committee for giving me the opportunity. So the topic is beyond the obvious and identifying subtle clinical signs in subluxated cataract and the surgical decision making. I do not have any financial disclosure to make. So the subluxated cataract, we all know, we will not go into the basic anatomy and everything. The compromised granules, mostly we get it most commonly in the trauma and pseudoexfoliation syndrome. And in trauma, you get the localized zonulopathy, and the pseudoexfoliation or Marfan syndrome, or retinitis pigmentosa, you get a progressive zonulopathy. Advanced is another risk factor. Prior intraocular surgery, where it's a post-VR surgery or post any kind of surgery, you should be very suspicious about the, and then we have a congenital and developmental. So it's very important to have an examination. Proper clinical examination is very important. Take the very good history, examine the patient in a detailed clinical as well as systemic workup, because it's very important to, in case of a Marfanoid or anything systemic disease. So the comprehensive ocular and systemic examination is very important. Examine the patient not in a primary gauge, examine in the eccentric gauge, in all eccentric gauges, and in a different posture like upright posture and the supine posture. Like in this case, we get a subluxation in the eccentric gauge. And if you come across a round lace edge or notch, this shows the absence of zonules. And then the depth of anterior chamber is very important. And you always correlate anterior chamber depth with the axial length. If there is a very shallow AC or if it's a very deep AC, this signifies the compromised zonules. And if phacodonosis is obvious, it's okay. But if phacodonosis is not obvious, try to elicit, suspect. And it's usually more clear in the dark light and small pupil when you don't dilate it. Or sometimes you need to do the jarring of the slit lamp, and most importantly, you can do the anterior segment OCT or a UBM. That will also help. So if the subluxation is obvious, you do all the detailed examination, but here you can plan the surgery. But importantly, what we do, we miss the subtle signs. So what are the subtle signs? You will sometimes get an exaggerated glow in the some kind of peripheral glow in some proper quadrant, and sometimes you will get a clear-cut iridolenticular gap. Usually iris and anterior capsule, the lens are opposed. And sometimes you will see the equator in the eccentric gauge, and if you come across a notch, or that again signifies the loss of zonules. And sometimes a decentered nucleus, you can figure out if there is no dense cataract by the sutural inverted Y sutures, it is in alignment with the corneal reflex or so. But in spite of doing a lot of things, we usually get it on the table. So here is a case, a very shallow AC. You could have seen the anterior chamber depth was very narrow, it's 1.4 millimeters, and the axial length was not corresponding to that. So that has a very high intraocular pressure, about 44, so we did it under mannitol. What I want to signify in this, that you will see the loss of movement of the entire capsular bag. So it was very difficult to get into the anterior chamber. We had planned for a pars plana vitrectomy to make some space in the anterior chamber. But in this case, again, I want to see that after the intraocular lens implantation, there is a lot of movement in the capsular bag. So this is a good case for implanting a CTR to stabilize the bag. So once we stabilize this, so this finishes the surgery. This is another case. So this is another case I want to highlight. The capsular axis becomes most difficult. When you will see the first puncture may become difficult, you will have to penetrate with a straight needle, and Utrata helps a lot. You can see here there is a movement of the entire peripheral capsular bag. So you can, and there was a fibrosis in the capsule as well, so we make a nick with the venous seizure, and we could complete the rhexis. So after completing the rexis, do it very gentle. So the cataract surgery was done, and again we implanted the CTR and finished the surgery. So because there is no lot of speakers, so I will request the chair to give me some one or 2 minute extra time. So the entire maneuver of the phacoemulsification may become difficult, whether it's a capsular axis or nucleus rotation. So you have to be very meticulous. So this is the classification, I'm omitting it. And you all know about that. If 25% of pupil is exposed, then it's a mild. Then if it's more than 50%, then it's a severe. So if you have a clear-cut obvious solution, you can plan the surgery, prefer local anesthesia, you can use aviminitol. Main incision should be away from the area of zonulopathy. If first thing is that if there is any vitreous, manage the vitreous properly by doing the bimanual anterior vitrectomy. So here the first thing that we have sealed the subluxated area with the high molecular viscoelastics, and do the capsular axis under viscoelastics. It will stain proper and it will prevent the staining of the vitreous, and try to achieve at least the 5.5 millimeter of the rexis. Here I plan to use Gupta anterior segment. I don't have any financial we work in a low resource setting. We don't have access to the AMA segment. So here we are using the Gupta segment. So you can fixate your bag with the Gupta, this capsular segment. And we have made a capsular flap for engaging with the iris hook. And then we implanted the CTR to further. The CTR does, what does CTR do? CTR redistributes the zonular strength. Whether it's a weak, it redistributes. It doesn't give the support. And the capsular segment gives the proper, so it fixates the bag. So this is a relatively hard cataract, so we did the cataract, and then so after doing the cataract surgery, we implanted the intraocular lens and we tied the capsular segment with the underneath the scleral bag. So the surgery completes here. So this is another surgery. What I want to notice you that this is obvious on that table. I was not able, so we deferred the surgery on that day. We started the surgery next day. So after doing we plan to do the capsular segment, but while I was making the rexis is it's not difficult, and even the nuclear emulsification was not difficult. So we didn't implanted the CTS in this case. We implanted the CTR, and cortical aspiration is again tricky. You have to do the tangential stripping. So I used the Simcoe cannula, I preferred it. So after implanting the CTR, we implanted the single piece intraocular lens, and you must check the vitreous at the end of the surgery by staining with the triamcinolone. So this is the intraoperative and this is the post-operative images of the thing. So you can see in this case, while you are making the rexis, when you suspect there is a case of trauma and you suspect the integrity of the capsular bag, what you can do, try to achieve the rexis of a 5.5 millimeter at least. We inserted the CTR, but the important thing is that I am not sure about the integrity of the capsule. So you can thread the CTR with the 10-0 nylon or any kind of a thread, and then implant it and you do the phaco. In this case, after doing the nuclear emulsification, we found out there is a vitreous coming out and there is a posterior capsular defect. So I had to take out the CTR, and we did the vitrectomy, and we did the SF oil implanted in this case. So the right size of CTR is also important. I mean, for most of the cases, the medium size CTR is sufficient. Yes, sir.
Brother?
Yeah, yes, sir. I'm completing. It's finished. Okay. Thank you, sir. Thank you. So it's a, there is a, this is another case where you can implant the CTR, but if you implant the faulty CTR, then it can go wrong. So never force the CTR work. The trick is that if you implant the CTR after 1/3 of insertion, support the CTR with the Shinsky hook. So in this case, we had implanted the CTR by using some force, and there was a decentered decentered IOL at the in the post-operative. So thank you. So think beyond the obvious, spot the subtle. History and dynamic examination gives clue. Flexibility and preparedness should be you should be prepared for greater difficulty. Subluxation often get missed pre-operatively. So thank you, and I'm really sorry for just taking
No
extra
problem,
time, sir.
no
Thank you,
problem.
sir. Thank you,
So,
sir.
so I'm not very good at giving comments, but I'll still try to do justice. The main thing is we have been given an idea of doing a rexes 5 millimeters or 5.5 millimeters.
Yes, sir.
That is meant for a normal case.
Yes, sir.
When you have a case with difficulty factor, try to do a, in such cases, try to do a oval rexes on the side where zonules are intact.
Yes.
When you have a longer axis, you can make big trenches which can be easily broken down into two parts, and it doesn't matter if it is slightly oval, because we have made this round axis our religion.
Yes.
First thing is this. Second thing about white cataract. Me and Dr. Bhalla have published an article in IGO telling managing a highly intumescent case is so easy. You take your child to the mall where you have that trampoline and tell him to jump in the center of the trampoline and then on the side of the trampoline. If he jumps in the center of the trampoline, he'll go 2-3 feet higher. And when he jumps at the periphery, he'll go just 2 or 3 inches higher.
True.
So right place to do a CCC start a primary rexis is not in the center. Because when you give a touch, there is a forward movement of the nucleus and the cortex forwards, which causes the Argentinian flag. If you make a rexis in the mid periphery, the forward movement of the cortex and the nucleus is checked by the intact central portion of the anterior capsule. So you will never have Argentinian flag if you make a rexis, primary rexis in the mid periphery.
Yes, yes.
Third thing, you should have a backup system in the form of glued lens or iris claw lens. You should
Yes.
not start without a backup system. So
Yes.
these are 3 points I wanted to highlight.
Truly, sir. Thank